Hello, everyone, and welcome to Death and Grief Talk Live with the Grave Woman. I am so excited because today I have the honor of speaking with Dr. Delon Canterbury, who is the founder of a very unique and interesting business called Geriatrics. Dr. Canterbury, welcome to the Death and Grief Talk podcast live.
Hey, it's so good to see you again, Joelle, and thank you for having me. Honored to be here today, share more about our journey, and yeah, hopefully give some good nuggets of wisdom when it comes to medication safety and advocacy.
Absolutely. Just for background purposes, I met you through the work that we do through Compassion and Choices, through
Mhm.
the African American Leadership Council, on which we both serve. But for those who are unfamiliar with you, could you please just introduce yourself and tell us exactly what it is that you do and how geriatrics was born?
Yeah, absolutely. It's my pleasure. Hello everyone. Again, I'm Dr. Delon Canterbury. I am a board certified geriatric pharmacist, and I'm also known as the prescribing pharmacist and founder of Geriatrics. So, what is Geriatrics? We are a concierge telehealth company focusing on medication management and reducing harmful medication use in our older adults. So we really focus on looking for prescribing cascades, duplicate medication therapies, high risk med use in older adults that may worsen frailty or falls or over sedation, constipation, you name it. Any side effect you can think of, we are the experts in finding out what may be a side effect or what may be another condition. And when we're able to figure out what meds may be causing what, we work with you and your family and your doctor to figure out how can we minimize the risk of harm and lessen your med list. That's right. We want you on as little medications as possible, not as much. So that's what we do. It's a very unique, very different. And really, I came into the geriatric space because I felt there weren't enough people advocating for less medication use in this population. We know that 750 older adults are sent to the ER every day just because of a medication side effect. And so we have a lot of people, billions of dollars we spend, millions of people put in harm's way because of a medicine. And we need to think a little bit differently when it comes to how do we educate clinicians to have positive conversations about reducing medications. And more importantly, why not empower the caregiver who's most likely going to be the one doing all the heavy lifting in this process? We cannot assume the health system is going to just magically figure out those issues. It generally doesn't, and which is why I created geriatrics so people can get quick, on the fly, objective information with no bias. And you have a pharmacist at your fingertips, no lines at CVS or Walgreens, no wait, just straight to you info about what your mom or loved one may be going through when it comes to those meds. So that's why I created this company about 5 years ago, and we've only been helping and touching more lives since inception. So yeah, it's a journey.
That is amazing, Dr. Canterbury. And I think, like many of us, especially in the African American community, and I'm sure across all communities, one of my core memories is taking my nana and my grandma and my older aunts to the pharmacy to get their medication. It was either a weekly or a monthly thing. They had to wait on their checks to come through, so their insurance would cover certain parts of their medication. And I think that what you're doing is so important because in our society, we are pushed pills for everything, for a headache, for cramps, and there's so many different options. So, I guess my second question to you is when you're taking someone off of medication, are you replacing that medication with something more homeopathic or more natural? What is that process? Because I know when I hear taking off medication, I my first thought is, well, what is going to happen to these symptoms I'm having? Are they going to come back? Am I going to get sick? What is that process?
Yeah, it's an excellent observation, right? Um, And what I find is that, yes, to all the above. And that's what I like about what we do is we personalize it to what the patient wants to do or what the family may want to do. In the world of geriatric medicine, a lot of the times, about 40 to 50% of people over 65 and up are taking at least one medicine that they don't even need anymore. They just don't know it. So where I start with is, okay, is this something that we can remove that isn't going to cause any issues or at least have minimal risk, right? There's some conditions that may be more chronic, like say blood pressure. And yes, if you are on 3 or 4, we take off 1 or 2, yes, we expect to see a spike and maybe sometimes return to some symptoms. But it depends on the condition. It depends on the medication we're talking about. It depends on how long they may have been on something, or sometimes people are just taking a product over the counter and didn't even know that they don't really need it. They just kind of heard, oh, I should take baby aspirin, so I should just take baby aspirin. Where there's some people who don't realize you don't even qualify for the benefits because you're already healthy. You don't need that. So what I'm looking for is an opportunity to stop something that just generally isn't appropriate, right? So that's number one. And then when we're talking about people where it may have been appropriate at some point, but we're checking to see if it's time to reduce the dose, that can be a little bit different. And so sometimes, yes, we are replacing medicines with lifestyle changes. We're replacing medicine with diet. We're replacing medicine with behavioral changes or deep breathing. Or have you considered maybe a medication that is non-invasive, like say a topical agent for pain, right? Have we considered using bombs or, Vicks Vapor Rub or Tiger Balm, stuff I grew up on, right? Are we using that for a cold to help with symptoms versus a pill that you ingest and can open up windows for potential drug interactions? So at our core, yeah, we're generally, ideally, the best way to avoid meds is to have an excellent lifestyle, is to have good dietary needs, function and behaviors. But generally, yeah, we're looking to find something that we can exhaust without using a medicine first. So sometimes it's, hey, have you gone to physical therapy to help with the soreness in your joints versus you taking 4 Advils and 4 Tylenols a day? Those are the type of methods we're going to want to employ first. And we're strictly using evidence-based, proven strategies to help people out. And if people want to try something more homeopathic or natural, we're going to try to explore that for them too. So we want to make people comfortable to have that option if they want to so fit. But we're not going to just, hey, just do whatever you want. We're very much regimented to what we know can work effectively.
So I am so curious to know what the response of the medical community has been to geriatrics and your work, because I can imagine that medical professionals may, just playing devil's advocate here, retort by saying, well, you're not a physician, you're a pharmacist. And I know my patients, I've been dealing with them for years, I've monitored them for years, and I have them on these medications for very specific reasons. So I'm curious, what has the response been to your work?
Yeah, overall, it has been very receptive. You're going to get your couple that are going to be resistant to any recommendations we may make. In general, physicians don't have a pharmacist to consult before they write a prescription. In fact, 13% of all prescriptions written actually have a physician review the medication with the pharmacist before it's sent out. And you'd be surprised at the amount of issues that may come because of the lack of this double check with the clinical pharmacist. So when I work with physicians, I'm showing that I have an expertise around medication management and drug therapy. And most are generally thankful because they just don't have that background. The truth is, pharmacists are indeed the drug experts, right? And yes, you're going to know your patients longer than me. Sure, I'm going to give you that. I want you to have that trust and relationship. And generally, the people that are most responsive are the providers that are open-minded, willing to listen to their patients. They're empathetic. So when I use my approach in creating a de-prescribing action plan, I'm doing it based on what the patient is saying. I'm doing it based on what they're saying patient's needs are. And if they weren't able to convey this to them, then hey, I'm going to be able to work with you and give you some extra info So we can do this as a team. We got to get out of the egos in medicine. And that's truthfully what's causing more harm is not having an ability to listen to people who are experts in their field, like your PT or OT or speech therapist, whoever. So yeah, we've had a couple doctors who were, who are you in the beginning. More so now, we're having way more that are like, oh my gosh, this is new. This is such a relief. I wish you can do this for all of my patients, which is a recent response from a primary care doctor under Duke Health. So we're slowly but surely changing this narrative, and people are seeing the value of pharmacists. I mean, the truth is physicians love pharmacists. They know how much we save each other's butts when it comes to health and healing. So it's all about coming with the approach of what's best for the patient and how can I be an extension of what you're already doing as a primary care provider.
That is absolutely wonderful. And we're going to talk about some special recognition and accolades that you've recently received in just a moment. But as you know, the majority of my audience are death care professionals and those who are morbidly curious. And I think that I've shared with you before that as an embalmer, I've been fascinated by the amount of feces that has come out of decedents during the embalming process. And I've been told by medical professionals that that has been caused by the constipation that you mentioned earlier due to the amount of medication people are taking at the end of their lives in some cases, and combination with the lack of movement, the inability to have bowel movement, the lack of physical movement, and perhaps dehydration. Other than constipation, what effects do medications have on our bodies post-mortem?
Yeah, that's a great question. Let's generally talk about what happens as we age with meds, right? So as we age with medications in general, all right, your kidney function goes down gradually, not as much as like your liver function, but as you age, your kidney function will go down, all right? The rigor of your skin decreases. So like just basically the integrity of it decreases, right? So that means your skin can get more porous, all right? Our gut, our acid in our stomachs, all of that is reduced. So the ability to secrete acid and digest is also slowed down, all right? What else? Brain marginally shrinks a little bit as we age. Our height decreases as we age. And so all of these things I'm bringing up because that affects how your drug response may be in the body. So as we age, we're already having slowed bowels and slowed digestion, and even further slowed absorption of some of the nutrients that we receive by eating. So when we take a medicine, that medication that was once, cool for a healthy you 50, 40 years ago, you may actually have a higher side effect profile if you're 80 or 85 with that same medicine or with that same dose. So when you understand this, you're able to get an idea of what the drug response would be in the body. So we get more sensitive to medications as we age. And especially as we're older, we generally, with the American diet, we're generally very dehydrated. We're generally just have a lot of, comfort fatty foods. And all those things compounded can cause constipation, right? Now, when we talk about putting the meds in the mix, there are a lot of the medicines out there are constipating. In fact, you're going to find most older adults are on some type of stool softener or some type of laxative just to keep things going. And frankly, a lot of that is from diet and just general changes in the body. But medicines stick around, and there are some medicines that stick around in the fat. There's some medicines that stick around more in our urine. But when you have these effects post-mortem, yeah, I mean, it's pretty common to see the bowels backed up. We're on a lot of constipating meds. When you're dehydrated, that actually adds to it. We don't have enough water. It's summer right now. All these can compound and cause issues. All right. So that kind of explains more the constipation piece. I'm trying to think of other affects, but in general, as we age, the body changes. And so you're going to have effects that we'll be seeing whether it's arrhythmias or sensitivities to mood disorders or changes in the drug dose. All those can be compounded. So that can affect anything. And that even includes if we start talking about interactions like with alcohol. Say we're drinking alcohol and we're taking medicines that may be sedative, and that can cause a fall or even a motor vehicular accident, right? Klonopin, benzodiazepines, people who take those medicines have a higher risk of having a car accident. So it's even worse if you've already had a drink of wine or two or whatever, and you're moving around. So you're shown to have impairment when driving. So there are effects of this that are compounded if you're older versus younger. So just another example of how that can play a role.
You opened a can of worms in my mind when you talked about sedatives and mixing stimulants with medication. The first thing that came to mind for me was Michael Jackson. And all saw his doctor go on trial basically for possibly taking his life with medication. But in situations like that with like Whitney Houston and Michael Jackson and even Prince, what medications, if you know, were they on, and what were the effects that caused basically their early demise because of those medications?
Yeah, that's a good question. At least the one I know of is with Michael Jackson, and he was actually on a number of different sleep medicines and sedatives. And I think the one that did Michael over was propofol, which you're going to see more so in like an ICU setting. But it's meant to just calm you down, sedate you, and let you relax while we're trying to do what we need to do, whether it's intubate or something. So propofol is used pretty commonly, but I think I even remember seeing Michael having a lot of anxiety meds, sleep meds, and when you compound all of them, and then the propofol was at a really high dose. Honestly, it's usually dosed on weight, and I think Michael was losing weight at that point. So I don't know if that was misdosed or what have you. I don't want to speculate on conspiracies, but propofol is a commonly used one. And I could say when you're combining that, which is already sedating, with other sedatives that I think Michael was on, it's a pretty easy recipe for disaster.
Another drug that comes to mind that is very prevalent in today's culture and has caused a lot of untimely deaths is fentanyl. What exactly is fentanyl, and what does it do to our body that causes this cessation of life?
Yeah. So fentanyl, guys, is a synthetic opioid. It's very much this cousin of your oxycodone, your morphine, all those. So that all those heroin, all not yeah, all those types of drugs are essentially in the same family. So it's an opioid. But why it's been, I guess, getting a lot of attention is fentanyl is like I can't even quote the number, but it's almost 120 times more potent than a dose of like one oxycodone, right? And so what people are doing is lacing like heroin or other products with fentanyl because it's an opioid and it can cause a little bit of euphoria, like all the opioids can cause, and a little bit of it can actually cause fatal overdose. So just very, very small doses needed to be lethal with fentanyl. So apart from using it to essentially, build your addicts like up, I guess, fentanyl, when you cut, your usual heroin or whatever, you're trying to create demand. And when you have a better high, with just a little bit less drug, it's easy for people to lace it because you're going to get a better bang for your buck, so to speak. So that leads to abuse, that leads to addiction, that leads to people now inadvertently dying from fentanyl because it does not take much to die from it, unfortunately. So that's also propagating this epidemic we're in. So it's the potency. It takes very little of it to put into a batch, and it also is going to lead to more revenue for your dealer. So that's why people are doing it, and unfortunately, that's why people are dying. And unfortunately, now we've got a version of it called carfentanil, which is actually the same drug but used for horses. So it's literally a horse tranquilizer. So it's way more potent than fentanyl, So now we're seeing more people using carfentanil to lace their products. And again, people are sadly dying because of this. So yeah, it's one of the strongest opioids out there, and it's good at what it does. And unfortunately, that's why people are in harm's way.
And so when we hear that people have passed away due to fentanyl poisoning, I guess would it be poisoning or would it just be use?
I mean, it's an overdose.
An
So
overdose.
yeah, you can say that it's poisoning.
Okay.
Mhm.
What happens to the body? What are the effects that it has on the body?
Yeah. So with most opioids, we're attacking these receptors in the brain that help with managing pain. But as it's doing that, it also hits some other receptors. It hits a couple of receptors across the body. And one of them is our respiratory system. So the ability to inflate and deflate our hearts. And so a lot of people end up sometimes having cardiac arrest because there's an inability for you to breathe physically. You're slowing the response for your body to breathe. And when that happens and there's less oxygen, you lose oxygen to the brain, you lose oxygen to the body, you pass out, and then you go into a coma, or you may have a heart attack because your heart is stopping because you just aren't getting enough oxygen. So it's respiratory failure is one of them. And then of course, just being so far sedated, you just don't, your body's not responding normally, and you forget to breathe and you end up dying.
Wow. Wow. So you were, if I'm not mistaken, honored by the American Society on Aging as Innovator of the Year for the year 2024.
Yes, yes. That was such
Congratulations.
a surprise. Thank you. Appreciate that. Yeah, completely unexpected for to have the American Society on Aging honor our work as the Aging Advocate of the Year, and it meant a lot to see the vision come to fruition. That's something I'm like, one, I'm like, who's really looking at me? And I'm just I'm doing what I'm supposed to do, but I'm really passionate about changing the paradigm of aging, and that's something I anticipate doing globally. My mission is to touch 1 billion lives. I don't know where that's going to be or how, but we're going to touch 1 billion lives, and we're going to find a way to de-prescribe as many meds as possible. So having the honor of one of the most prestigious aging advocacy nonprofits in the world, it was humbling to share the story and to share why this led me today to this journey. So definitely got to give a shout out to Leanne Clark Shirley, the current CEO and president of ASA, and all my mentors and partners that have helped to vet, nominate me, etc. That means a lot. So it's crazy because I was the youngest person among the participants that year who won this year who won. So that meant a lot to be on that stage with such amazing people.
I can feel the genuine excitement and shock as you're speaking. And I think, like I said in the beginning, I think what you're doing is so amazing. And I want to talk a little bit about what you said about seeing the vision come to fruition. Talk to me a little bit about you told us the professional story. I want to hear about Delon as a little boy and what inspired you to take the track into the pharmacy world and how that birthed the vision of geriatrics.
Yeah. Little Delon, that guy. Yeah, I was interested in pharmacy for a minute. And I guess thank my mom for that. She was really big on herbal medicines and natural remedies. We have a Caribbean family, so very common to use those type of approaches to heal. So I was good at math and science, but I was a really, really shy kid. I was an awkward, shy, clumsy kid. I know I'm tall, but I couldn't play sports. So I was just, let me stick to these books and video games. So I was a nerdy kid in the back. Um, but I learned to, I like to heal. I like to know what it takes to heal, like what drugs are doing, what's medicine doing, like how do we heal the body. I was fascinated with that at a young age. And yeah, so I would say my mom encouraged me to get into pharmacy in middle school, and I've always had a passion for that. And a lot of it was because of my Caribbean roots. So fast forward to later, uh, I got into pharmacy school, did my thing, graduated, um, and I was maybe, I don't know, I graduated in 2014, so I became a pharmacy manager 2015. Um, but yeah, kid wise, I was a tech. I was volunteering. I was just trying to figure out why do these people know so many damn drugs? Like, how do you know all the drugs? Like, that's a lot of drugs. I want to know the drugs because that was what piqued my interest. So knowing the drugs, knowing the mechanism, knowing which ones came from which plant, trying to understand the history of the plant. So like, there's a whole 99% of our drugs are based on a plant. Most people don't always know that. They should, but they're made in a lab and it comes from a plant structure. And that was really the giddy part for me, was natural products and knowing what plant can lead to the next wonder cure in the jungle or something. So that was something I was interested in. But I learned when I got into the career that wasn't always it's cool, but it's not like it's a long journey, so to speak, like 100-year journey to go into the research side of plant development. So I said, let me go more public health and start touching people directly with relationships and conversing with folks. So I realized I had a gift for getting real vocal and telling people, just dissuaging fears with people when it came to COVID and misinformation and vaccinations, and so I started to lean towards more advocacy work and getting involved with aging. And so a part of this journey was seeing my grandmother unfortunately fall victim to inappropriate medication use. My mom was taking care of her, and she had dementia and was given an antipsychotic medication to manage her dementia symptoms. So, mind you, very inappropriate. The medicine completely worsened her symptoms, spiraling out of control, being angry, irritable, hiding things even more, sundowning, you name it. And it was hard for the family. So my mom mentioned on a refill at a pharmacy that I'm just tired of seeing Granny get worse. Like, what's going on? And the pharmacist took the time to do a review and advocate and found that it was that one medicine that was causing a lot of my grandma's issues. So thankfully, that pharmacist advocated for us, and my grandmother was able to get the medicine stopped. And over 2 to 3 weeks, she got back to her normal self. So much so that we were able to move her back to New York to her nursing home, and she was able to live to see 90 years of age, which we were able to appreciate, celebrate with her. So that got me angry in the world of like, how many people are just slowly dying from a health system that isn't holistically looking at people or their family or their environment or resources, or just in general having a pharmacist say, hey, this is actually going to kill you. If you continue this, we need to stop and just something else. So that woman saved my grandmother. So I'm like, how can I provide a service that could save yours? And that's where really my inspiration behind geriatrics came, was seeing my grandmother go through this, seeing how someone advocated. And I'm like, wow, we've got 10,000 people turning 65 every day in this country. And there are only 1% of doctors are geriatricians, 1% of pharmacists are geriatric trained. We don't have enough people to manage their care, period. We don't. So let's do something now to advocate for less meds and inform people that, you know what, maybe you don't need all 15 meds. Maybe we could stop 2, or maybe we could stop 1 and see how you do for a few months. And if you're doing fine, then guess what? We will probably stop some more. So that's the philosophy, is less is more when it comes to these meds. And our older adults, they have a higher risk of side effects and issues. So we need more people to advocate. You don't have to be a doctor to advocate. You literally need to ask questions like, does my mom really need to be on all these meds still at every medical visit? When's the last time you've had a comprehensive medication review with a pharmacist or a provider? And I mean, go through each and every med and see if the dose is appropriate, the timing is appropriate. Like, when's the last time you've had someone review all the herbals and all the over-the-counter medications or anything that you may be taking? When's the last time you had a discussion about just how do you feel about the medicines? Do you actually like taking this? Do you feel comfortable? Does it make you feel better? Do you feel worse? What are you experiencing? Like, get to know your body and don't be afraid to ask, what's the lifetime benefit of my loved one or myself taking this as an 82-year-old? Do they need this for the next 8 to 10 years of life? Do they really need it? Right? And when we're able to just have a healthy dialogue about this, you can kickstart conversations and you can get medication stopped that were probably no longer serving you. That's the mission.
Absolutely beautiful. What is the lifetime benefit of taking this medication? That opens my mind to my last question, which is about medical aid in dying. In some situations, the lifetime benefit of taking a medication is to actually end the life. And I'm curious as to how medications are selected for medical aid in dying and how those medications work.
Yeah. So, are we talking about like medications in hospice or people that might be towards the end of life and we're doing more palliative medicines to help them feel comfortable? Is that what we're getting at?
We're talking about full spectrum end of life, from hospice, palliative care, and then ultimately medications used in medical aid in dying.
Oh, okay. Got you. Yeah. So, yeah, you'll find that in the palliative world, there really is a very formulaic. Generally, in palliative care and hospice, they have the philosophy of reducing meds that you don't need anymore in general. So we're going to generally stop the chronic meds, depending on, of course, if they're, soon to death or they're just in a course of recovery. But in that, you're gonna generally see the same meds. You're gonna see morphine to help with pain. You're gonna see antipsychotics like Haldol to help with any like potential agitation, which is subjective. So I'm putting quotes up. You'll see sedatives like Xanax, like benzodiazepines, things to kind of calm you down. You're going to see Tylenol usually, so anything with pain. So we're generally just trying to make you as comfortable as possible. All right. Now, sometimes, unfortunately, some facilities may pull the trigger on using some of these agents where the patient isn't at all close to dying or end of life. They're just in a transient or acute setting or change. And unfortunately, I've seen some of those meds used, and it has brought about premature harm or potential death because there has been a miscommunication on the goals of this person's care, right? Because I had a stroke doesn't mean I'm going to die. It just means I had a stroke. So don't throw me the cocktail because I'm agitated and now I'm becoming hooked on the pain meds, or now I'm over sedated, and it may show as a different issue, but really as if she's declining, but really it's the medicine. So that's why I wanted to break that down, because I've seen that do a wonder of good for people in their end of stages and you're transitioning. You want to be comfortable, right? There's nothing more guilty than someone denying someone medicines for a process that can be very painful. So completely on board with that. But I want to caution us and not just knee jerk to just use to everything in the hospice toolkit when there is still hope of life and benefit. So that's one thing to note. And then, of course, we have the larger spectrum with medications used in dying, and basically regimented and regulated processes in that. And they do what they're supposed to do. And of course, depending on what state we're in, that's going to be variable on which state, which laws. But I think it's important for people to know that there are choices in this. There are people to know that there are options when it comes to how you may want to choose, how you may want to pass. So again, having these conversations with advanced care planners, end of life planning conversations, having those wills set up, those trusts, your 5 wishes, your advanced directives, super critical to have that documented so in advance how things may go. And I would say generally these things, when it comes to the actual passing, generally it's some medicine that's going to slow and stop your heart rate, and you pass peacefully in your sleep. Like it's not as traumatic or as painful as I guess physically seen that we may see in movies. So really, it's a silent goodbye. I would say for some of those medications that are used for this.
Dr. Canterbury, I just want to say thank you so much for spending this last 40 minutes with me and having this conversation. It's been fascinating for me, and I'm sure for the viewers as well. I have your Instagram page up on the screen. If anyone's interested in following Dr. Canterbury, he can be reached at Geriatrix, GERIATRX. And where else can people book a consultation, learn more, or have a conversation with you to learn about what their options are as far as prescribing?
Yeah, we conduct consults for anyone in need. But yeah, check us out on any social media. We're definitely on LinkedIn. You have a YouTube channel. We have a series called The Red Pill versus the Blue Pill. We usually do a live every Thursday at noon talking about the need for deprescribing to change our healthcare system. But you can find us everywhere. Geriatrix.org is our key website. You can book a consultation there, or send me a direct message on Facebook, Instagram, you name it. We're all over the place. So yeah, happy to be here.
Thank you so much, Dr. Canterbury. And thank you to each and every one of you for tuning in today. Live life, love hard, and we'll talk to you next time.
All right. Take it easy.